as well as for next year's cohort to possibly incorporate some of the discussions we'll have today and see how we can best support in this area for next year. So that being said, I do have a few kind of prompts or questions that I can throw out, and then we will, and thank you for Dr. Restrepo for being here. And he will also he'll be here to moderate and kind of push that conversation as well. But we really want this to be kind of open, everyone to share if they have any questions or concerns, please. And then we'll go from there and then hopefully get a natural conversation going. So I think to start us off, it would be a good idea to kind of introduce the issue or the topic. And I want to start by just putting the question out there of exactly what is low birth weight and why is it significant here in Colombia, but also just overall, why it's such a significant and important issue.
So can anyone kind of give some example? I'd like to get one person from USF and then someone from Universidad CES who's with us to give a response. So what are some of the challenges that are being faced with low birth weight related to malnutrition with families from the perspective of the US and from the perspective of Colombia?
So Jesse,
yeah.
So if you guys allow me, I want everyone to know that I am a pulmonary critical care doctor, and when Jesse asked me to moderate this, the first thing was, oh my God, I'm a pulmonary doctor. I don't have idea of this, even though I'm from Colombia. And I did my medical school back in Colombia, but I started to try to read a little bit about the topic, and I found very interesting information. And it's crazy how, even though it seems like it's been a little bit of progress since I left Colombia back in 2005, it still is a topic that, unfortunately, for my country is still a huge problem, right? So couple of the, if I can say, a couple of the numbers that I found, and somebody can help me later to define what is low weight at birth. But it is something that is 20 millions of infants worldwide are born with low weight, 20 million. And it's about 15 to 70% of all the infants born that are born at any given time, right? What it was striking for me is 85% of those 20 millions is in the countries in development, which Colombia counts as one of them, right? So it's a huge, staggering number. This number is huge, and in 2024, who can believe that this is still a public health issue on an immense majority of the countries that are getting in developed. So I just wanted to frame the importance of this conversation and try to give a little bit of urgency to the topic, because, as I said, it seems like it's been a little bit better, but if I remember correctly, when I was in medical school back then, it still is very similar, and very few progress have been achieved on 20 years. So this is a crazy number.
Thank you, Dr. Restrepo.
I think the thing why low birth weight is such an important topic is not necessarily just the immediate effects that low birth weight can cause the baby and the mother during the sort of the perinatal and postnatal period, but also later in life. There are lots of studies that show that low birth weight can be associated with diabetes, with high blood pressure, a lot of these long-term chronic issues that a lot of people face. And when you have a baby that's born at a low weight, at a low birth weight, you're already at a heightened risk for all of these issues.
Thank you, Fawn.
Does anyone know the weight limit to define low birth weight? Is 2,500 grams on the reviews that I was able to do. 2,500 grams. And apparently it is regardless of the gestational age or other conditions that can develop. Excuse me 1 second, guys. I'm trying to move the conference to my computer.
So you're in a unique position to kind of give your perspective from both the US side and from your experience while living in Colombia. Can you speak to that a little bit?
Hello, can you guys hear me?
Oh, yeah. Sorry, I think you were switching your. I was mentioning, so I think you're in a unique perspective where you can provide both your experience here in the States, or what you've researched here in the States, and kind of some of the experiences you may have had while in Colombia.
So in Colombia, when I was there, I was able to do, I mean, the medical school, the internship, and the rural service, right? So it was something that was very, very, very present in our daily life practicing as a physician, as a general physician. Remember that in Colombia, you can practice some degree of medicine when you finish your internship and when you finish your rural service, right? You are called a general practitioner or a general physician. So when you do roles like that, and when you do like a rural service, you are exposed to a lot of these patients, right? And you can see the impact of this condition back in Colombia. And that's what I was saying, that it seems like, and when we did all the studies with epidemiology, with public health, it was kind of a very prevalent condition back in those days, in the 90s and early in the 2000 decade. I mean, when I came to United States, right, and I don't know much of maternal care or neonatology care because it's not my area of expertise, but it feels like here is a very rare occurrence, and most of the low weight birth is associated to clinical conditions that produce that low weight, not really nutritional factors associated with maternal development. So it's striking, right?
Yeah.
Doing some reviews, as I said, it seems like in Colombia there is a direct association with maternal nutrition and with socioeconomic status. If you guys remember, or whoever went to Colombia to do the trip, in Colombia, we have what we call the CISBEN, right? The CISBEN is basically the people that is poor, that don't have means, so it's kind of a social health service, right? And it's divided in different numbers. CISBEN 1, 2 to 4, I think, or 5, I don't recall. And the incidence and prevalence of low weight at birth is directly linked with the lower CISBEN population. So yeah, so it's something that is very prevalent still on our population over there in Colombia, especially in the rural areas. I don't know if I answered your question, Jesse.
Yeah. think we have some students as well here from Universidad CES. Si están escuchando, pueden responder en español o en inglés, como quieran, y podemos aquí traducir cuando sea necesario. Pero si los que están de la Universidad CES, si quieren responder a la pregunta, ¿cuáles son las realidades del tema en Colombia? So if you're joining us from Universidad CES, feel free to respond in either English or in Spanish, and we can translate it.
Hello, everyone.
Hello.
Hello, I'm Laura Perez. I'm from Universidad CES. This is my first time speaking in English, so I'm gonna do my best. I want to add something to that the Dr. Ricardo said. Is here in Medellin, we have like a very important number or a statistic about like the food insecurity. But comparing this statistic here in Medellin to the other cities, like for example, the rural areas, as he said, but in Guajira or in Amazonas, in the Colombian Pacific, in this place, the statistics are going to be bigger. This is related, has a very important relation with the difficult access to the health services that this population usually have. So if we as doctors wants to prevent the low birth weight, it's going to be very difficult because when this population want to access to the prenatal controls or the prenatal programs, it's going to be very late. So our interventions and the results of our interventions are going to be like more difficult for the same reasons, for the food insecurity that they have and the difficult access to them to the health services.
Thank you so much, Laura. And for a follow-up question, can you identify or have any thoughts on in terms of what the main barriers are that's preventing that access and being able to reach those services that you mentioned? Is there anything that may be able to be done to facilitate that from a healthcare provider side or in terms of engaging the community? What are your thoughts on this? Puedo también preguntar en español y si ayuda. Vuelvo y hago la pregunta también en español por si acaso. Esencialmente, según lo que usted estaba diciendo, ¿qué cree usted que pueden ser unos factores o que usted pueda identificar o que haya notado que realmente afecta a los individuos poder recibir esos servicios? O también como de su parte como profesional, que son cosas que uno podría de pronto hacer para poder mitigar esas barreras.
I would say, can you guys hear me? I want to make sure. I would say one of the ways to kind of approach these barriers is to do home care visits, which is something that I know is beginning to be prevalent in a lot of areas, both the US and in Colombia. Went on some of those trips, as Brian mentioned earlier. That is a great way to meet people when they're not able to leave their homes, especially because the issue of malnutrition, even with mothers, is not necessarily just lack of access to healthcare, but it's also limited access to food. So in many areas, it's also the concern about food deserts as well, where there may be some food access in the area, but it's not as healthy as in other areas. So the home healthcare kind of helps comprehensively bring the health services to them. But then also part of it is helping them make a plan to approach these barriers and be able to overcome them as well, even food insecurity as well.
So I think to answer, oh, Luciana has the hand raising first. Go
Sorry,
ahead.
Doctor Restrepo, my bad. If you need to talk, that's fine as well. Like I can let you go.
Go for it. Go for it.
But what I was gonna say to add on to what Namira said, like essentially, even from that public health perspective, when we're looking at low birth weight, I know there are different dynamics in Colombia for like racial makeup, ethnic, splits within the United States were very cut and dry with kind of things. We have the non-Latino or Hispanic, Hispanic or Latino, white, Black, Asian, etc. So those racial divides are a little different, and the socioeconomic status looks different in Colombia. But here, kind of working in the food sovereignty realm, which is like people's access to food, having access to the right to grow your own food and everything, it plays a large role with that, because where are they getting food? Like from the trip, seeing how people operate in their food culture and how that's a part of it, it definitely, is a big part of why certain systems are set up. I think too, especially with, I think the nutritional students at CES, which was amazing that they did have a program where they were actually showing mothers how to properly breastfeed and what happens if they're not latching, what happens if you don't have enough milk production, is a part of it as well. Having those interventions in communities that aren't just, accessible. To people being deployed into home visits could be a solution as well. But food banking looks different in the United States. And I know in Colombia, it's going to be a little different as well. But those access programs are a big part of it. Unfortunately, just like it is in the United States, as it is in Colombia, from what I've observed and seen, we all battle with diet-related like health conditions such as diabetes, hypertension, cardiovascular disease. And it doesn't help any new mothers when they're eating these foods that aren't necessarily going to encourage the most milk production. If you're under a high level of stress, that's a big part of the factors too. And then mental health as we know it, even though in the United States, it may be a different, I guess you could say, way that we approach mental health, it's still a big important issue long-term for any community internationally, Colombia or the United States. So I think the big goal is looking at where people were accessing their food, kind of hopping on what Namira said, and to encourage that intervention, because I think as healthcare professionals and as people who are in public health or in health service in general, you kind of have to approach the person as not a patient, and you have to approach them as a holistic individual that has a lot of different factors that are a part of it. I think that Profe Sandra, like we saw from CES, had a wonderful diagram that I had to find. I know Brian knows what I'm talking about. Everybody else who went on the trip knows exactly what I'm talking about. But it showed how the system is interacted and their relationships that they have can affect things. And of course, we know that, there's a brain-gut connection. So if people are not, having, I guess you could say, wholesome food, they're not going to be able to help with the kids as well. But it's going to affect everything long-term. The main goal, though, I think that overarching thing from what I'm saying is that we need to encourage more programming for, better options for community. That includes people in Colombia and in the United States, because there's still a gap. There's always going to be a gap. But encouraging programming as well as other facilities that are going to do those home care visits, that are going to do food banking events, that are going to keep, pursuing nutritional information is going to be what's important, because socioeconomic status doesn't seem to move from what I understand. In some areas in Colombia, the poverty is really hard to get out of the poverty. Like communities, impoverished communities, than it is in the United States. From what I heard people saying, it was a different dynamic. So like if you're living through multiple generations of poverty and you have low birth weight, you had a low birth weight. So boom, your kid has a low birth weight, and then your grandchild now has a low birth rate. There's a higher chance that you're going to have a low birth weight in your family line. But if you were able to have an intervention that stops that early on, you could kind of cancel that cycle of malnutrition that affects people later on. Because stunning growth, not just that, mental development, as well as like diabetes, hypertension, cardiovascular disease, like it all is intersected. So if we can start that early on and create a positive conversation around food, as well as advocating for healthier food options and where they can actually access food instead of, oh, well, we're just making food choices. We're just making food choices instead of here's something for you to eat that is healthy. I think I also saw, and I know I'm sorry I'm talking a lot. I know this is a conversation, but I saw also while we were there at in La Comuna Dos, they had a vertical garden growing actually in the community. So like spaces like that where we're allowing people to take back and to actively participate in gardening environments will also give them access to food. Even if it's not on the large scale, it's smaller scale, especially in communities that don't have access to supermarkets or other typical type grocery like dispensaries, I guess you could say, in the United States. But
So I think what I was going to say was, I think to answer that question, we need to answer first, what are the factors, at least in Colombia, that are more associated or strongly associated with the low weight at birth, right? And there are few reviews out there, and I was very happy to see actually that there are very nice reviews. But it seems to me, and after I reviewed those, that there are few key points that were associated with low weight at birth. One was the availability of prenatal care, okay? And it was significantly different between those mommies who were able to have visits before before delivery and those who didn't. And then they analyzed the number of visits of prenatal care. It was very significant difference between 1 to 3 or more than 3 and 1 to 0. So even one visit before delivery was significant different on the incidence of low weight at birth. So when we think about healthcare policies, trying to intervene those, knowing that at least one visit can change the outcome of the pregnancy in terms of weight of the baby might be important to know. The other the other few factors that were associated with low weight were a number of pregnancies. So if the mommy had more than 2 pregnancies, was associated with low birth, substance abuse, if it was a single mother versus a mother with a significant other present at the moment of the delivery. So all of those are factors that can be intervened with policies of healthcare policies from a state and from healthcare systems that can be intervened, and it seems they are trying to be intervened back in Colombia. So again, I think the question is, what are those factors? Identify those factors and try to intervene those factors. As far as type of nutrition, it was interestingly, because they tried to differentiate between rural, or at least in the report that I read, they tried to differentiate between the access of food in the rural areas and the city areas. And it seems like that factor was important as a beneficial factor on the rural areas. So I don't know, access to more natural food, people like growing their own type of food and things like that, instead of living in the city and living with the nutrition that is happening in the city. So that was interesting, but the type of nutrition, as Luciana mentioned, was a factor associated with the prevalence of finding low weight at birth. Those were kind of the more significant to me that I was able to find on the reviews.
Dr. Restrepo, quick question as you were talking. Did you see anything specifically about the teenage risk for like teenage mothers for a low birth weight as well? I know that was something that we noticed that they said there were a lot of teenage moms.
They define below 15 or more than 16. Having said so, the prevalence of pregnancies below 15 is going up, but yeah, that was one of the risk factors for low weight. And the reviews are a little bit old. The latest review that I was able to see was from 2017. So they are still a little bit low. And I remember last year when we went to Medellin, one of the things that we learned was the teen pregnancy actually was growing dramatically in Medellin, at least, and it can be a mirror of what is happening in Colombia. But yeah, it was a factor.
So for someone in Colombia can answer this, what is the rate of teenage pregnancy in Colombia? Is it growing? Is it steady? Is it declining? And then what is the average age of pregnancy?
Um,
I'm sorry.
Laura Valentina.
Yes. I was in these few weeks at obstetrics, so I see this topic a lot because I think the pregnant in teenagers are growing in Medellin, and one of the most young woman that I see having her baby this week, it was like around 14 years, and that's maybe the average age for the teenagers to be mothers, and it's also related with the topic of this reunion. The babies have more complications the next hours to their born. So yes, I think the average age is 14 or maybe 15. And I think this is a very important problem in Medellin because it's growing the statistics. And I cannot say what is the reasons, but I think for what I see, I didn't see statistics, but for what I see these past weeks is growing like the numbers of teenagers that are pregnant.
And Jesse, I think last year when we went to the trip, that was one of the topics that is carrying more concern when we received the talk from the city. I forgot the name of the program, but I remember they said that the pregnancy in teens doubled in prevalence on the last 5 years. I forgot the name of the lady that gave us the talk from the city. But yeah, that seems to be a very concerning situation.
Yeah, teen pregnancy is increasing, but the age of pregnancy is lower. So whereas before you saw pregnancies at 16, 17, you're now seeing them at 14, 15. And so they're getting pregnant younger, I should say. Now I had another follow-up question. I know that several people mentioned home-based care. Can someone from the US and someone from Colombia give me an example of how home-based care for young mothers works? So what does it work, and what is an example of a success of home-based care? Y si quieren hablar en español, está bien, pueden contestar en español.
Yo también puedo en español.
Claro que sí.
So I don't have much experience lately, but I know when I was doing the rural service in this town, the hospital and the local city develop a program where we physicians will go to the communities and visit the houses of patients, where the leaders of those communities will identify a risk. And one of the risk population that they identified was the pregnant patients, especially on the area that I was working. especially on the indigents, the local native indigents used to live. So we started to develop a program that we will go every week to see these patients over there. That program in 1 year and in that town during the year that I was there changed dramatically the incidence of pre-labor, preterm labor. That's the term, I think. I'm not sure. The preterm labor on pregnancy, specifically for that population. And we kind of analyzed that these people from these communities, indigent communities, don't want to go to the hospital. They live too far, and it's way too much for them to reach the hospitals, or they don't have a trust on the healthcare system as per se, like in a hospital or something like that. But when somebody approached them, they were very open, and that changed, as I said, that year that I was there. And I think few other programs still happen, and we saw it last year. Sorry guys, I couldn't go this year, but we saw it last year, right? You guys went from houses to houses to do the surveys, to analyze the kids, to wait and measure the kids. All those home care, I wouldn't say home health, I would say home care programs, I think have a very significant impact in terms of healthcare policies.
What about in the US?
So I don't have a lot of experience in specifically giving healthcare health visits in the US. However, from research, it is clear that it has helped reduce maternal health risks overall. And it is especially for communities that don't have as great of an access to healthcare, specifically people who are Black or Hispanic, that historically in the US are discriminated against in the healthcare system. So having those home care visits to meet them where they're more comfortable, it's less stress. And overall, the type of care that they would provide would be like vitals, checking their vitals, which is really important to make sure that there aren't any symptoms of preeclampsia going on or diabetes during pregnancy. So it is definitely beneficial for maternal health.
Especially when you're talking about distress in the medical system. I know Dr. Restrepo, sorry to be another person from the US, but I know Dr. Restrepo talked a little bit about the distress of the indigenous people that he has home care visits with, but especially within the Black community in the United States, unfortunately, there's a lot of distress in the medical system because of medical racism, as well as some other dynamics that interfere with people's continuum of care. Whether they opt out of it or it's insurance status or vice versa. A lot of programming has expanded to include prioritizing women such as WIC, but unfortunately, there's still like a large gap of people, especially those who are unhoused, who are on the streets that don't have access to care and may not be close to a facility where they could get access, is where the big barrier comes in. But I would say the success stories, like Namira is saying, is coming when people are able to go into like these houses to build trust. If it's somebody you see all the time, whether they're not a physician or they're just a health professional in general, you're talking to them more. Especially with public health, it's really important to emphasize health literacy and how, unfortunately, the patients are living with themselves 25/8, I guess you could say, so much more than they're interacting with their physicians in clinical settings. So a lot of the times the full picture is not captured. And if you don't have the proper tools of how you should be, protecting yourself or your baby or vice versa, it's not going to end up with the best health outcomes. So even just having someone sit down and have conversations around education with maternal issues has shown a benefit. That's why I've seen a lot of programming with kids if they're parents of the children, that they were able to discuss with them what are their options, how you're able to breastfeed, when you should take prenatals, where you can get prenatals actually for free, which health departments have it. And that's been beneficial within communities, especially in the Black and Brown communities.
And I will add, one of the primary findings for what was found in these studies on free care visits was actually reducing accidents and injuries in general with as the mother progressed in her pregnancy, especially if she has to rest, be bedridden, and then also preparing the house for a baby to come to the family and make sure it's safe in that aspect as well.
Thank you so much, everyone, for your input and insights so far. I did want to ask a question. Thank you, everyone, so far for everyone who has shared and answered. I did want to throw in a question to see if you have any experiences or thoughts. And I do think this has been touched on already a bit, but are there any cultural or societal stigmas that have been associated with malnutrition? And what effect can that have on interventions and those the support system those individuals or groups may have? So I open the floor to anyone, and if I can get a perspective both from the US side and the Colombian side, that would be amazing. También voy a hacer la pregunta en español. Entonces, la pregunta era, ¿es que hay estigmas, sean culturales o sociales, que están asociados con la malnutrición? Y es que eso tiene un efecto en esos individuos y el sistema de soporte que esos individuales podrían tener.
I think in a lot of cases in the US, our, I guess, like social system can be quite harsh on mothers of children, especially since there's so much emphasis on like making sure the baby is okay, especially a low birth weight baby that's in the NICU and is really, you know, like struggling to stay alive, I guess. But there definitely is stigma against the mother, especially since a lot of society feels like it's sort of her fault that the baby is going through all of these difficult times. I think it's slowly changing. There have been lots of research on how like healthcare worker perceptions and healthcare worker actions towards the mother can affect the mother's mental health and long-term development of the child. And so I think that's something that we're trying to work on and making some progress on.
Anyone have any thoughts or opinions? Posiblemente alguien en Colombia sobre el tema.
La pregunta es, ¿existe el estigma contra las madres que tienen niños que tienen dificultad con la nutrición?
Hola, voy a responder en español.
Claro.
Yo diría, no sé muy bien si la palabra es como estigma, pero yo considero, por lo que, pues como por experiencias que he tenido, que por parte del personal médico hay como un trato como despectivo hacia estas madres cuando tienen pues como hijos de bajo peso al nacer o con hijos pues como que a lo largo de la vida no han tenido un cuidado muy óptimo en su alimentación, en su educación, en la esfera pues como que se quiera tratar, porque se cree falsamente y me parece pues como mal hecho, de que simplemente es como negligencia por parte de los padres a un cuidado óptimo a un cuidado óptimo de los hijos. Entonces, una vez como que esa idea mal fundida en los médicos hace que haya un trato hacia esas mujeres como de manera despectiva y eso limita mucho como la relación médico-paciente, haciendo pues como que los pacientes cojan pereza como por decirlo de alguna manera, aunque esa no es la palabra que precisamente quisiera usar, pero evitan como ir a las atenciones médicas, evitando esos tratos a los que ellas previamente han estado expuestas por parte del personal médico desde una idea como mal infundida, porque puede como que desde un inicio el médico piense que por negligencia la mamá no le da un cuidado óptimo sin indagar como qué hay detrás de todas de estos como determinantes sociales que pueden estar como en el contexto de esta familia.
Muchas gracias, Laura. Um, to I'll do my very best to summarize. So, what Laura was sharing is that in Colombia, from her personal experiences, what she's noticed is that at times when parents or mothers that are going through these issues, and for example, the child is malnourished, there seems to be a misconception that it is due to the parents or the mother's negligence, which can be erroneous given that sometimes these practitioners don't take into account the context or other underlying factors. And so when this happens, it can erode the patient-physician relationship and kind of may lead to suboptimal care because of this bias certain practitioners may have in this situation.
All right, so we're running close to our end time. But I want to pose one last question to everyone, and give it a few minutes of thought. From your perspective, what is the biggest barrier for these mothers who have low birth weight children to gain the assistance needed to address that? And how would you resolve that barrier? And so what's your solution to the barrier that you've identified? I'd like everyone to give one response to that to kind of get an idea of what that would be.
I guess I would say cost, dinero, like money. That's what I'm gonna say. And then I can let somebody else go, I guess.
But what's your solution?
Solution is subsidized programming for that. I don't know how the system is set up. I know in Colombia it's different because they have different levels of like social insurance, but not everybody necessarily qualifies for the plan. So I would say maybe like a more socialized system in the way that like WIC and stuff, if you have qualified for care, regardless of your economic status, you have access to food because one premise of like food sovereignty is regardless of how much money you have, you should have access to nutrition. Like you should be access to food because everybody needs food to survive, to live, to thrive. So I would say subsidized care. That's going to include education around food, access to prenatal vitamins, as well as like nutritional resources. That's what I would say.
I would say, kind of linked to that, that the biggest barrier is just general food insecurity. One of the problems with specifically is that it's that for a lot of families it doesn't cover like past, I believe, 3 years or so. So even if they have SNAP and WIC, SNAP isn't necessarily enough to cover. I work for a loss prevention organization. We have a lot of women who come in with needing food vouchers to supplement that. So a solution I think would be to expand to be until the child is not a dependent anymore. And just in general, having those type of programs for specifically for children. I help.
So I would say that one of the biggest problems, I think, is the lack, or at least in Colombia, the lack of support to research and trying to investigate the causes of the origin of these problems and try to investigate and develop the solutions, right? So it's the lack of support from state level to many levels to a stimulus to investigate on these causes, right? Because, and I say this because, do you guys are familiar with what the kangaroo care is? The kangaroo, the mommy's kangaroo. Are you guys familiar with that? I know that my people on the CES will be familiar, but the people here in the US, are you guys familiar or no? It seems like no, because of the size.
Can you go over it?
So kangaroo care was developed in the 70s, in the 80s in Colombia, in Bogota, Colombia. And it was with the baby boom that was happening in the 70s and the amount of babies that were being born with low weight at birth. There was no sufficient incubators to maintain all these kids, right? So what these two pediatricians did was those babies were kept under the clothes of the mommy in the chest, skin with the skin, okay? They will provide oxygen, tube feedings, but the only interventions that they did was skin to skin with the mom for a big percentage of the day. Actually, it didn't need to be with the mom. It could have been with nurses and or surrogates, women, but always to the chest of these kangaroo moms. And that was a dramatic implement tool that was implemented to change the incidence of low weight. But it was actually developed in Colombia back in the 80s. And I was reading that now is implemented or is used in probably more than 95% of the healthcare systems in the planet. So as simple as that, right? So I think one of the things that needs to be done is incentivize research, creativity, and the healthcare systems to try to come up with the causes and the solutions for these problems.
Just to add on, kind of going off what Dr. Restrepo just said, I also think that one way that we can kind of push the needle, as they say, is not only having conversations like these, but raising individuals and populations' consciousness about the issue, normalizing it, and kind of as Laura had spoken to, some possibly malattributed biases existing. So with that being said, being able to talk about it and, making populations, given the education, making people aware of basically the realities. And a lot of this sometimes is investing more in research and making it more widely available to both individuals and the populations. And so I think that's something that can also help. I'm not sure if that's necessarily a solution, as the question was, but definitely, in my opinion, in the right direction.
Let's see. There's someone from Colombia that wants to respond.
Perdón, ¿podría traducirla, por favor?
Claro, la pregunta, ¿cuál es de lo que hemos hablado y de lo que has visto, cuál es la barrera más grande para brindar apoyo a las madres que tienen niños con bajo peso? ¿Y cuál es tu solución a esa barrera?
Pues yo diría que la barrera más importante es como lo que decía al inicio, y es como lo difícil que es para estas poblaciones acceder a un sistema, a una institución prestadora de salud. No es necesario ni siquiera que vaya a una de tercer nivel. Desde un básico nivel se le puede prestar como la ayuda o la atención necesaria que una materna necesita para algo tan fácil como intervenir para prevenir lo que es el bajo peso al nacer. Me parece a mí que esa es como la barrera más importante. Sin embargo, como proponer una solución igualmente me parece muy difícil porque si bien esa es la barrera más importante, esta barrera se ve influenciada por muchas otras barreras que hay. Sin embargo, pues como que me parece como soluciones muy apropiadas lo que la universidad hace, que es como apropiarse de la Comuna 2, ir a visitar casas, estar en contacto con el colegio, llevar apoyo ginecobstétrico, de psiquiatría, de medicina familiar, entre otros, porque a pesar de que estamos hablando de pacientes específicamente embarazadas que van a tener que como producto va a ser un bebé de bajo peso, todo esto se ve influenciado y está como está englobado en muchas esferas que implica la salud, salud mental, salud social, salud económica, o sea, una salud como integral. Entonces, si la barrera más importante es como el acceso a la salud y la solución que me parece a mí como de las más viables es precisamente lo que hace la universidad, ir apropiarse como de esas poblaciones y atenderlas, atender su salud desde todas las esferas.
Thank you, Laura. To summarize, one of the significant barriers or most important factors would be access, essentially. So having individuals and populations to have access to particularly primary care was emphasized. And so as far as a proposed solution, one thing is that what the university has already put in resources and does, for example, in Comuna 2, being able to provide care not only in the context, in this case, of maternal and child health, but also from all different facets of care, given that they all feed into the overall arching health of that individual. So essentially, being able to increase access and then being able to provide those services to those populations who currently lack said access.
So we reached our time. So I wanted to say thank you to everyone who came to participate. Muchas gracias a los que nos acompañaron hoy en este conversatorio, que me parece muy importante de poder conseguir y poder seguir hablando de los temas que afectan a las poblaciones, sobre todo a las personas que son más vulnerables. Entonces, esas son las madres y los niños. Entonces, muchas gracias. Thank you, everyone. This has been a fantastic conversation to be able to have these chats, around, what are some of the most vulnerable population groups in the areas where we work and do global health, both in the United States as much as it is in Colombia. Thank you to Dr. Restrepo for being here. And although she didn't get a chance to speak, Dina Rodriguez is also here from Universidad CES. So thank you both for representing both USF and Dina for representing Universidad CES. Very much appreciative. We're going to post this on YouTube and share the link with everyone so that you can also share it with other individuals who have an interest in this topic.
Right, thank you. Thank you.
Thank you so much, Jesse. I just wanted to give a shout out to Jesse. My name's Ellen, and Jesse's been phenomenal with getting this off the ground. And thank you so much, Brian, too, for your insights and your leadership with IHSC. So thank you all so much. And thank you to our friends in Colombia.
Oh, thank you, doctor. Thank you to all the students. Dr. Ricardo, so nice to see you again. And dear Jesse, and all the students that I've seen before. And of course, our students from CES. thank you also for participating, and really thank you for this invitation. I think it's wonderful to share, and I'm very excited about learning of how the students have gathered so much about our culture during the visit. And I'm not an expert in the issue, but in public health a little. And what I've heard from your students from USF, well, I'm very happy to learn that they have now this intercultural, professional experience, and they've learned so much. So I think this is a wonderful opportunity for both our universities. Thank you so much.
Thank you so much.
Thank you, everyone.
Have a good night.
Thank you for
Thank
the
you,
invitation.
everyone.
I can't wait because my